The azoles are probably one of the most important drugs in our fight against fungal infections, and with time they are evolving as well, increasing the spectrum of coverage, and they are also fairly safe drugs which can be used for a prolonged duration. We have fluconazole, which has activity against candida, cryptococcus, and coccidioides. We have voriconazole, which has an added coverage of aspergillus. It's actually a drug of choice for aspergillosis, and also scedosporium fusarium. And then we have posaconazole, which also has activity against zygomycetes. Same is with isavuconazole, which also has activity against the zygomycetes. Itraconazole, it has activity against histoplasmosis, blastomycosis, and cutaneous candidiasis, and it is very much similar in spectrum to voriconazole. It is bacteriostatic against candida and critical illness, and that is why azoles are not the preferred agents in seriously ill patients where we want to use echinocandins. There are better outcomes data with the use of echinocandins, and echinocandin group of drugs are endorsed to be used in the presence of severe fungal infection. When we look at the candida, the major species are the albicans, the cruzae, glabrata, parapsilosis, and tropicalis. And candida cruzae is inherently resistant to fluconazole, so you can always consider voriconazole in the presence of candida cruzae. We may also consider an echinocandin or an amphotericin. Candida glabrata and parapsilosis may be resistant to azoles, echinocandins, and even amphotericin, and this is a global concern. Same is with Candida auris, which is newly detected and could be resistant to all available antifungal agents. The azoles inhibit the 14-demethylase responsible for converting lanosterol to ergosterol, a major component of fungal cell membrane. And this ergosterol is unique to a fungal cell wall, is missing in humans, and that is why this selectivity of antifungal action. The azoles have excellent bioavailability, good tissue penetration, including those in the meninges, and so in a lot of CNS infections we use them. It can be used primarily if the fungus is sensitive or as consolidation therapy after the use of an echinocandin or amphotericin. In critical illness, fluconazole is given as 12 milligrams per kg loading dose and then 6 milligrams per kg, and generally the duration of therapy is 2 weeks beyond culture negativity. So if someone has culture positive fungal infections, we serially do the cultures, and the day it becomes negative, we continue our antifungals 2 weeks beyond that. In the presence of deep-seated infections, the duration of therapy is much longer, and in the immune compromised, this could be lifelong. The use is for prophylaxis in high risk groups, like in transplant patients. Hematopoietic transplant is one classic example. And voriconazole may be used if additional mold coverage is desired, otherwise, it's generally fluconazole which we use. Empirically, it can be used in high risk groups, and then we can review at 4 to 5 days with the clinical and biomarkers, and then decide on whether we want to continue our empirical therapy or not. The point is that if fungal infection is suspected, antifungal should be started early for better outcomes, because delayed initiation has been shown to have poor outcomes. Voriconazole generally shares cross resistance with fluconazole for candida, and this should always be considered when we want to switch over from one agent to the other. The major adverse events are hepatotoxicity, GI upset, QT prolongation, metabolic interactions, which is very important, and a lot of drug interactions should be considered, because these drugs may be used in patients who are immunocompromised, who are candidates for transplant. They are on multiple immunomodulating agents, immunosuppressives, and this should always be considered, how the drug levels can interact and lead to lower or higher serum levels. They can cause cytopenias, and prolonged use can be neurotoxic. Especially with voriconazole, there could be visual disturbances, photosensitivity, and the cyclodextrin, which is there in intravenous voriconazole is nephrotoxic, and that is why with higher creatinine levels we only use the oral formulation of voriconazole. If an IV formulation is needed, we may consider a substitute to voriconazole. Posaconazole is available both as oral suspension, delayed release tablets, and IV formulation. It's fairly dynamic in terms of how we can use it, and it can give you additional zygomycetes cover and can be used where we desire coverage for zygomycetes as well. So overall, the azole groups have evolved with greater coverage, although in critically ill patients echinocandin is still the drug of choice, but maybe these scenes might change as the azoles evolve in the class and as we have newer agents available in this class.